I'd like to welcome you all today to the first 2025 webinar of the CKD Clinic Network. For any of you new to the network, I'm Monica Bollier. I'm a nephrologist in Vancouver who's been fortunate to chair this network for the last several years. I'd like to start us off in a good way by reflecting myself that I live, work, and play on the traditional, ancestral, and unceded territory of the Squamish, Musqueam, and Tsleil-Waututh people. I'm very grateful for this. A bit of housekeeping today. As you've seen, the video will be recorded, so you can share it with your teams. If you have any questions, the Q&A chat is active, so you can feel free to type your question in, and there'll be some time at the end. And Selena and I are always interested, as we usually plug on any topics you'd like to hear about or any speakers you'd like to hear about. So feel free to type those in, send an email, and we'll help to arrange that for our next session. So it gives me great pleasure today to introduce our speaker and welcome back Dr. Janine Farragher. Janine is an assistant professor from the Department of Occupational Science and Occupational Therapy at the University of Toronto. She's the recipient of a Canada Research Chair in Life Participation in Kidney Disease. That's amazing. And she's an active participant in this area of research, and will share some of that with us today. She holds a Crescent New Investigator Award and has been an active contributor on many of the resources you probably use in your clinics, like My Kidneys, My Health website that we've highlighted previously. And her overarching research objective is to clarify the broad range of cognitive, psychosocial, and environmental factors that impact life participation in CKD, most importantly, so we can start to proactively target them. I really look forward to your presentation, Janine, and we'll pass it over to you.
Great. Thank you so much, Monica. And thank you so much for having me today. I am actually really excited to be able to take this opportunity to talk about life participation in kidney disease, and really start to think about how we can move towards pathways that will actually support life participation in this population. And I actually want to start this conversation by talking a little bit about a revolution that's been happening in nephrology research really over the past 15 years or so. So traditionally, the direction and focus of research in nephrology was set primarily by researchers. Researchers were the ones who designed the studies, decided on the important targets for change, and on sort of the health outcomes that they were going to measure as indicators of treatment success. And this is really the way that health research has traditionally been conducted, and the dominant way that research in nephrology was carried out as well. We had a bit of a revolution start about 15 years ago when there was a collective sort of reevaluation, I would say both within and outside of Canada, about whether this was the best model. And so the idea of patient-oriented research really started to emerge. So patient-oriented research means engaging patients, their caregivers, and their families as partners in the research process. So really prioritizing their voices and their perspectives. And this model has been redefining how we make sure that our research is really going to matter at the end of the day and make an impact. So this kind of shift in philosophy has sparked a number of really kind of cool initiatives that emerged within kidney disease. One of those that you might have heard of is the CanSolve CKD network, which is really using a partnership-based model to conduct meaningful research in kidney disease that involves people with kidney disease very heavily in the research process. Another initiative that emerged from this patient-oriented research revolution was the Standardized Outcomes in Nephrology, or SONG initiative, which is being led by a group out of the University of Sydney, but it's really a global project. And the goal of this project was to develop a set of core outcomes and outcome measures for clinical trials and for other forms of research in kidney disease that can really be used kind of universally across the world. And the neat thing about this project is that those outcomes are being chosen based on consensus priorities of patients, caregivers, clinicians, researchers, and other people who are involved in the field. So it's really a partnership-based approach to deciding what those research priorities should be. So the way that the SONG project has gone about this is to identify 3 tiers of priority outcomes to measure in research. The highest tier being core outcomes, which are those that are chosen as being really critically important by all of the different stakeholder groups. And the song exercise has been done in 8 different kidney disease populations, involving people from 63 different countries. So again, this is a really big and wide-reaching project. Now, of course, you wouldn't be off base for thinking that the outcomes that emerged as being highly important would be the ones that we often kind of think of in health research. So survival, kidney function, hospitalizations, infections. But something really cool also happened, which is that this outcome that I don't know if anybody really saw coming rose to the top of the priority list again and again. And that outcome was life participation. So in the song kidney transplant group, the song PD group, the song kids group, and the song GD group, life participation was chosen as one of those core outcomes, again, that top priority tier. And even in the groups where it wasn't there, it was often mentioned as being really important in relation to other outcomes that were chosen, for example, like fatigue. And so I think this finding has really highlighted that this is something that we need to be thinking about more in kidney disease. And I personally was really excited to see that patients and stakeholders had highlighted this as being so important, because I myself am an occupational therapist, and supporting life participation is really the focus of what we do in our profession. And so really, I think the things that I hope to accomplish today are to think about the importance of life participation to people with kidney disease, to talk about factors that can affect their life participation, and then to start to consider some possible pathways that might exist to promote life participation among people with kidney disease, some directions that we might be able to explore going with that. So first of all, the million-dollar question, what is life participation? What is this term that patients actually came up with independently in the SONG project? So the SONG groups defined life participation as being the ability to participate in life activities that provide a sense of fulfillment, enjoyment, control, and hope. So this could include activities like working, studying, spending time with family, traveling, pursuing hobbies, enjoying recreational activities, and doing social activities as well. So they kept the definition very broad, just basically being able to do all of the things that you want or need to do in your life. And we've done some research to really support this kind of broad definition of life participation, because we found that people with kidney disease have a lot of different goals and priorities. In a study we did where we asked people on dialysis to set life participation goals for themselves, those goals ended up spanning doing household tasks, self-care activities, hobbies, socializing, playing sports, and other things as well. So people with kidney disease really want to be participating more in a lot of different areas of their lives. And I think that's helpful to recognize and to emphasize, because we've tended historically to place our focus and research on the concept of being able to function, which really sort of reduces the standard to can you manage to get through a day safely, rather than really recognize the importance of being able to thrive, and to be able to do the things that bring fulfillment to your life as well. And this is a quote from the song PD report that I think really highlights that. And the statement made was that the ability to participate in life activities was seen as the fundamental goal of their treatment, because it symbolized being able to live a life without being confined by their disease. And so this is really the aspiration of people with kidney disease, to realize their full potential, to avoid having their life being confined by their health in any way. Unfortunately, the data we have suggests that many people with kidney disease do experience limitations because of their health. When we look at data from the hemodialysis population across the world, for example, we can see that the percentage of people who are able to be totally independent with their self-care activities, so things like being able to shower, manage medications, grocery shop, is less than a third in most countries. So many people, particularly on hemodialysis, are relying on others for help. Even in earlier stages of kidney disease, the likelihood of experiencing some type of limitation with being able to perform those self-care tasks is significantly higher than in people without kidney disease. So this challenge is really common across the spectrum of CKD severity. And we see this in employment rates as well. So people experiencing kidney failure especially have much lower rates of employment than the working age general population. So one study found that employment rates were 26% in dialysis, 37% in pre-transplant, and 38% in transplant recipients, which compares to about 80 to 85% in the general population. So many people are not able to participate in the workforce either. And then again, thinking about the impacts on leisure and socialization as well. So people with kidney disease have talked about how joys in their life are foregone, how they're unable to fulfill their relationship roles the way they'd like to. For example, in previous research, they've talked about not being able to travel, to go out dancing and visiting friends, not being able to go to the mall, play with their kids, or have a romantic relationship the way that they would like to. And so kidney disease really does appear to affect life participation in many different domains. So the big question is why? What specifically are the barriers and how do we identify those barriers so that we can start to work towards some tangible solutions? In occupational therapy, we have a helpful approach where we think about there being three kind of major barriers to life participation. And this allows us to hone in on potential solutions. So the first barrier is a person's physical capacity or personal capacity. Sorry, people might not have the physical, the cognitive, or the emotional ability to participate in an activity. And they might not have the knowledge or skills to compensate for those limitations. The second type of barrier is environmental. So the environment that the person is in, whether we're talking about their physical environment, the social environment, or their cultural environment, that environment might not be set up in such a way that it fully supports them doing the activity that they want to do. So it might be a poor match with their skills and their capabilities. And then the third type of barrier to life participation is the actual activity itself. So the demands of the activity might not be a good fit with the person's capabilities either in the form that it currently is. So just to think about an example, so say there's a person in a dialysis unit and they say, I'm not able to prepare meals for my family anymore, and this is something that's really bothering me. So the reality is that this person could be facing a lot of different types of barriers to doing that task. So at a personal level, they might be experiencing weakness, fatigue after dialysis. They might be experiencing pain. They might have cognitive challenges that are a barrier. Depression might be a barrier. So these are all things that we know are common in people with kidney disease. And these are things that could be interfering with their ability to cook for the family. They might not have the knowledge or the skills to know how to overcome or compensate for those challenges. So in terms of the environment, the kitchen might not be set up in such a way that it meets their needs. It's not a good fit. Maybe it's inaccessible for them. Maybe it's inefficiently organized. Maybe they could use having their cupboards labeled or have access to adaptive equipment. And they might also be lacking a social support system who can help them with the task. And so those could be potential reasons why they're not able to cook dinner for the family. So related to the environment. And then again, at the activity level, maybe the meals that they normally cook are just too complex or too challenging now, given the other barriers they're facing. Or maybe trying to incorporate all of the dietary requirements of kidney disease, it's made cooking too complex and too difficult to do. So when we break it down this way, there are a lot of different reasons why people with kidney disease might not be able to do the activities that they want or need to do. There are a lot of different types of barriers to life participation that are likely at play here. And so recognizing the complexity of this gives us potential solutions to explore. And this approach, again, is really the basis of what occupational therapists do. So I work full-time in research, and the goal of my research program is really to move us towards finding specific pathways that can promote life participation in kidney disease, so that this is something that we are better equipped to proactively address in kidney disease care. And I have sort of three angles that I've been approaching this from. And the first is working on identifying research priorities for this area. So again, life participation, I think, kind of came out of left field in terms of being a core outcome, one of those top outcomes in nephrology. But now, knowing how important it is to patients and stakeholders, the question we ask is, what do we already know about how to promote life participation in kidney disease? What research has already been done that can help to guide us and move us forward in this area? And are interventions designed to do this at all? And if there are interventions, what type of interventions are they? What types of those barriers that I just mentioned are they targeting? And are we overlooking any factors that could be important or could be helpful? So I supervised some occupational therapy students in conducting a series of scoping reviews in 4 major kidney disease populations. So pre-dialysis, hemodialysis, peritoneal dialysis, and kidney transplant recipients. So we looked at 6 electronic databases for literature, and we were really looking for any qualitative or quantitative article that examined an intervention to address life participation in one or more of these kidney disease populations. And really, our goal with this was to describe patterns in the literature, identify research gaps that would help us to set those directions for where we should go next in terms of what to study, who to study, how to measure outcomes, etc. So I think the first thing we found was that promoting life participation generally has unfortunately not really been a priority in nephrology intervention research thus far. You can see in this table that the number of studies that had life participation as their primary outcome that was being targeted was very limited. The largest body of literature we found was in hemodialysis. But generally, there was just a really small number of studies that have looked at life participation as an outcome at all, even when we looked at studies that included it as a secondary outcome. So there just isn't much literature out there to inform interventions that could be used or could be helpful. So the second thing that we found was that across all 4 of those populations, a lot of the studies that were done were of medical interventions. So things like taking medications, different approaches to dialysis. And then most of the remaining studies were of exercise-based programs, so physical exercise. The focus of all these interventions we found was basically on improving people's physical ability to complete or participate in the life activities. And what we tended to see very little of were studies targeting any of the other barriers to life participation. So, addressing cognition, addressing emotional well being, skill building interventions, for example, making environmental changes that could support life participation, or activity related changes. And so there were a lot of knowledge gaps, and really there just hasn't been a lot of work done in this field. Again, looking at how addressing these barriers actually impact life participation, which was our research question. So there are more studies out there looking generally at these factors and what happens if we address them, but not their impact on life participation. And just as a comparator to what we see in other populations who have complex health challenges and who tend to experience some degree of disability. So, for example, in traumatic brain injury and stroke, a systematic review found 491 articles just studying the impacts of cognitive rehabilitation alone. And that review was done in 2014, so that number would be even higher now. So when you compare, our literature in kidney disease is extremely limited and limited in scope and limited in breadth. And again, the types of interventions that we found were also at odds with what people with kidney disease have actually said that they would want in a rehabilitation program. So in one study, people talked about wanting support to address psycho-emotional social needs. Again, wanting a multimodal program design, wanting something that addressed their symptoms and would incorporate some symptom management strategies. And so really, I think there's a lot of work that we can do in this field to better meet the needs of people with kidney disease in supporting their life participation and enabling them to do the life activities that are really important to them. So in my research program, we've done some work to start to identify mechanisms and treatments that could address life participation in kidney disease. One of those areas that we've looked at is cognition. Now we already know that cognitive impairment is quite common in people with kidney disease, especially in the hemodialysis population. However, we have less of a grasp of how much cognitive impairment actually factors into the overall life participation challenges that people on dialysis have. Again, we've tended to focus on physical limitations and how physical limitations impact participation, but less on how cognitive factors might be at play. So we know, less about how cognitive impairment affects people's ability to do things like, for example, paying bills, managing medications, cooking, doing other life activities that tend to be cognitively involved. So I have a graduate student who just completed a study involving 105 people on hemodialysis from 2 dialysis centers in Toronto. And we asked participants to do 2 functional cognitive tests. So often what you're asked to do during a cognitive assessment, a traditional cognitive assessment, tends to not be very practical. For example, count backwards from 100, draw a cube. They're things that you probably don't actually normally do in your everyday life. And those things don't always accurately reflect people's ability to actually do their practical tasks. So functional cognitive tests are designed to look directly at practical tasks. And we use 2 tests called the MMA, and the UPSA-B. And these 2 tests assess people's ability to pay a bill, schedule an appointment, and do a medication management task. And when they're doing those tasks, a trained observer is scoring their performance and noting challenges that they are encountering while they're attempting to do the tasks. So first of all, we found that about 30% of people displayed significant challenges on the UPSA-B, which were paying a bill and scheduling an appointment. And over 50% had challenges on the MMA-A task, which again was learning a medication regimen. So functional cognitive challenges were common in our participants, more so in the participants that we had from in-center dialysis units compared to self-care dialysis units, which is something that I think we expected. And when you consider the types of people who usually participate in research versus those who might choose not to, these numbers are probably an underestimation of the true burden of functional cognitive impairment in this group of patients. So the MOCA is an example of a cognitive screening test that we sometimes use in kidney disease care, just to, again, as a preliminary step to detect cognitive challenges. We found that it correlated fairly well with the UPSA-B functional cognitive test. So people who scored as impaired on the MOCA were far more likely to also exhibit impairment when they were doing those functional cognitive tests on the tasks on the UPSA-B. And in fact, many people who were impaired on the MOCA didn't have difficulty with the UPSA-B tasks. It was mainly when the MOCA scores got into the range of moderate to severe impairment, so in that sort of below 20 range, that we started to see impairment in the functional cognitive tasks as well. And so again, I think that this study hopefully helps to highlight the potential impact that cognitive rehabilitation interventions could have for that group of patients who did display evidence of functional cognitive impairment. So when I talk about cognitive rehabilitation, what that refers to, it's an evidence-based set of approaches, evidence-based in other populations. Again, not much research in kidney disease, but certainly has a large evidence base in other populations. And there are approaches that can either restore cognitive functioning, or more often they help people to learn to compensate for any cognitive deficits that they might have. And so I think that these results demonstrate that there really is a need to explore using these types of interventions for people with kidney disease as a potentially impactful way to support their life participation. So another area that I've done some work in is fatigue, and looking at how we minimize the impact of fatigue on people with kidney disease. So we know that fatigue is the most common symptom of kidney disease. It's been estimated that up to 70% of people on hemodialysis, for example, experience fatigue. It's very prevalent in other kidney disease populations as well. In a study done here in Canada, fatigue was chosen as a top 3 research priority of people on dialysis. And in the US, similarly, patients identified fatigue as one of the most important physical symptoms that they wish that we would find better treatments for. So it really is a widespread issue associated with kidney disease. And we also know that it has a profound impact on life participation. So in the Song Initiative, patients explicitly talked about how the impact of fatigue on their everyday life was the worst part of their fatigue experience. So I've done some work previously to develop an energy management education program for people on dialysis. And so what does that mean? So energy management is really about using strategies that are going to help people to be efficient and conserve energy when they're going about their everyday tasks. So in the program that I developed, we sort of talk about 7 key energy saving strategies, which are eliminating a task that really isn't a priority, finding a way to simplify a task, using assistive tools to make a task easier, organizing the environment, for example, labeling cupboards, putting things in easier reach, asking someone to help out with a task, repositioning during a task, for example, sitting on a stool while you cook or chop vegetables, or slowing down a task, so breaking it up into chunks, for example, to make it more manageable. So in the energy management program that I developed, which is called the PEP program, people learn to apply these strategies by completing 3 short web modules, and then doing 4 to 6 sessions with a trained clinician to apply the strategies to hopefully facilitate their personal life situation and life goals. So helping them to really work towards being able to do things that are important to them. And we did find that the program was potentially effective in a pilot randomized controlled trial. So the people who completed the program were far more likely to achieve their life participation goals. At 3 months post-intervention, so after they finished the program, more than 60% of people who did the intervention had achieved their life participation goals. And that was compared to just 25% in the active control group. So we definitely saw evidence of a potential effect there. However, the major challenge that we have with the PEP program is one of implementation. So we interviewed the nurse coordinators who provided people with the intervention during that pilot randomized controlled trial study. And we asked them about their experiences providing the intervention. And we found that they had significant challenges. For example, with implementing a problem-solving strategy that we incorporated into the program. They just felt that they weren't qualified or well-trained enough to do that. We also listened to some of the session recordings to further examine their fidelity to the intervention protocol, so how well they actually carried out some of the key components of the program. We found that some of the facilitation strategies were consistently used, but others weren't. And again, this was after they underwent considerable training and had a pretty extensive written resource to refer to as well. And I think part of the reason for this is that this type of program is typically administered by trained occupational therapists who have studied these approaches for months, even years sometimes. The nurse coordinators, again, they just felt that they weren't qualified to be the intervention administrator. So where to go with this? So I'm currently planning a project to modify the PEP program so that it can be self-administered by patients. So this is a bit of an experiment. Rather than having individualized sessions with a clinician, patients would complete the program on the computer. There would be a bit of tailoring, although not as much as working with an actual person, of course, but we want to see if that would be effective at all to solve sort of the trained personnel problem that we do have in the dialysis units. And if this works out, it could potentially be an easy resource that patients could access to help support their life participation and promote fatigue management. But we don't know whether this would be effective or not, so you'll have to stay tuned for those results. So the final piece of the sort of overall puzzle that we're trying to tackle in my research program is developing measurement tools that can accurately capture life participation in people with kidney disease, so that we have a way to identify people who need further support, and also that we have a robust way to actually measure the effectiveness of interventions and how they actually do affect life participation. So I am a member of the SONG PD and SONG CKD life participation working groups. Again, those international research groups that I spoke about at the beginning that are looking at sort of core outcomes in nephrology. And as part of those groups, we did 2 scoping reviews to look at how life participation is usually assessed in people on PD and in people with pre-dialysis CKD. And really what we found was that there was no consensus best practice approach. The most frequently used instruments were subscales of quality of life measures like the SF-36 or the EQ-5D for anybody who's familiar with quality of life measures. So these are examples of where you see life participation sort of being touched on in those measures. So for example, the EQ-5D asks one question about whether there are problems doing usual activities. And the SF-36, again, another pretty prominent quality of life measure. It has a few more questions. It asks about the impact of physical and emotional health on work or other regular daily activities, for example. So these quality of life measures do touch on some aspects of life participation. But I think the limitation of these sort of sub-skills or sub-questions is they weren't constructed with as much rigor and attention to detail as a dedicated life participation measure would or should be. It would kind of be like trying to assess depression using a quality of life screen. It's just not designed for that. It might touch on emotional health, but it's not been fine-tuned to really measure the construct of depression. So I think that's a similar issue that we have trying to measure life participation with a quality of life scale. And there really just aren't many measures that have actually been validated in people with kidney disease either. So we don't even really know, even with the measures that are being used, if they capture the issues that are most important to people with kidney disease regarding their life participation challenges. So essentially, we're kind of lacking the tools to measure life participation in kidney disease in a way that we can really trust and that we know is relevant and valid for people with kidney disease. So I have been working on or contributing to two semi-related projects to help us move forward in this area. The first is developing and validating brief outcome measures of life participation, again, in collaboration with the song groups. And the second is validating the PROMIS social participation measure in people with kidney disease. So for the first goal, the song groups have been working on developing brief assessments of life participation that have actually been co-developed by people with kidney disease. And that's really to be sure that, again, they do capture what's important to patients. So these tools are great as screening tools to identify people who may need further assessment and follow-up. And they're also great outcome measures for clinical trials to see how interventions affect life participation, which is something that was really previously lacking in kidney disease. And the Song PD and Song kidney transplant life participation measures are already publicly available, actually. They can be found on the Song website. So if you're interested in accessing those and using them, they are available. And I think if you Google like Song nephrology, you'll be able to find the Song website and sort of navigate from there. So those are out there. And the second goal that I've been working on in my research program is validating a very robust existing measure of social participation for use in people with kidney disease. So the measure is called the Patient-Reported Outcomes Measurement Information System, Social Participation Measure, or PROMIS-SP, which is much easier to say. So the strengths of the PROMIS-SP measure are that it's thoroughly validated and highly reliable. It's been validated in thousands of people with varying conditions, and it really focuses on social participation more in depth as well. So it's a great follow-up measure that could be used to learn more for patients who are screened as having difficulty with their life participation, to learn more about what specifically with their social participation is a challenge. It's also individualizable, and it can be used to compare social participation with other diseases for research and advocacy as well. Again, since it has been validated in so many different populations. So I've been working with a team in Toronto to validate this measure in kidney transplant recipients first. And the tool has been found to be very valid and reliable in this population as well. So it is a useful tool to use in kidney transplant recipients, and we're looking to validate in the dialysis population as well. So that's, in a nutshell, some of the work that we've been doing in my research program to, again, try to identify some pathways that can actually promote life participation in kidney disease. But I think it's worth pausing to note that we do continue to be constrained by the lack of trained rehabilitation professionals that are working in CKD care settings, who really could be doing so much more to address the issue of life participation with our patients. So this is a slide that I show my occupational therapy students in their first week in the program. And they learn right up front that the entire purpose of occupational therapy is helping people to gain access to, initiate, and sustain life activities that they want or wish to pursue, and how, where, when, and with who they wish to pursue them. And our students then spend 2 years studying how to promote participation in occupations, which to us means all life activities. So work, education, social participation, self-care. And we really do have access to a tremendous number of intervention approaches that could make a real difference for people with kidney disease. So this was a set of guidelines that was recently developed about the role of a specialist renal occupational therapist, and it really outlined some of the things that we could be helping with. So, for example, recommendations for adaptations to the home environment, vocational rehabilitation, supporting home dialysis through environmental assessment and task analysis, again, cognitive assessment and rehabilitation, seating and postural assessments. So these are services that kidney patients really should have access to. And yet there's a review that just came out from the UK. Unfortunately, we don't have a similar study from Canada at this point. But in the UK, they found that out of 42 kidney care hubs that they surveyed, only 22% offered any form of outpatient rehabilitation services, and only 7% of dialysis units did, while 9% of pre-dialysis CKD care programs and 7% of kidney transplant programs did. So essentially what this means is that unless you're hospitalized, you're usually not getting access to rehab support as a person with kidney disease. They also found that the scope of rehab services provided were extremely limited when they were there. So less than 20% of kidney hubs offered intradialytic exercise programs. Only 22% provided rehab-based symptom management support. And less than 10% offered support with meaningful activity during dialysis. Less than 5% offered direct life participation support. And the top 4 reasons for having such limited support were, of course, predictably lack of funding, but also lack of time among existing staff, prioritization of other services, and lack of qualified personnel for the role. And I think when we think about this quote from one of the participants in my studies, which really exemplifies, I think, as we've seen, how a lot of people with kidney disease feel, he said, trying to get back to your normal life is the hardest thing. I'm in a state right now just because I can't do all of those things anymore. I can't be me. There's a lot that slowed me down. And so I think perhaps it's time for us in CKD care to really rethink how we provide services and prioritize services that are going to meet some of those really important needs of our patients. So I would just like to thank all of the people and the organizations on the screen for their support in my research and my career. And I would be happy to take any questions now. Thank you so much, everybody.
Thank you so much, Janine. That was excellent and a lot to think about and figure out how we can incorporate. Maybe if we could drop the slides, if that's available, so those of us on can see each other. I'd just like to open up to any questions that anyone might have. So maybe I'll start. So this is going to be a little hard one, but
okay, fire away.
So, practical advice, for those on the group inspired now to go back to their CKD non-dialysis clinics and try to at least be a bit more aware and mindful of the life participation goals. Any practical advice of kind of first steps or anything you can give us?
Yeah, well, I think, even just having the conversation and sort of having it on the radar that this is something that is so important to patients. I think it's not necessarily something that's incorporated into routine assessment. And so I think even just having it on the radar as something to really make sure that you're asking about would be maybe the first step. I think, again, the use of some of these standardized measures to really measure and assess where people are at with their life participation is another sort of helpful step, because I think being able to capture that can only help in terms of ultimate sort of advocacy and really sort of identifying that this is such an important and widespread kind of challenge. And then I think, connecting people to services, especially when it comes to rehab, might be the most doable sort of measure that can be taken at this point. So I think, again, it's rare to find kidney care programs that are equipped with people who are experts in rehab. And really, if we're talking about rehab. So I think, sort of figuring out what resources and what other teams, either within the hospital or within the community, are available in your area, and trying to see whether there are programs that could be addressing some of the major concerns or barriers that people with kidney disease tend to be facing. And just kind of making yourself aware of some of those and maybe making use of those a bit more is also a potential step that could be taken. So yeah, that's kind of what comes to mind.
Thank you. Yeah, that's great and really practical and implementable advice. Any other questions from anyone on the call? On behalf of the network, thank you so much. I'm sure people can email you directly if there are
Of course,
questions. Yeah,
absolutely. Yeah.
and we will be in touch with respect to our next session. Thanks everyone for signing on and have a great day.
Thank you, everyone.